Uh, we will start the next session. The first talk is on art of managing post-operative surprise in cataract surgery. We all have experienced this, and we will hear from the expert, Dr. Chitra Ramamurthy. Over to you, madam.
We want the previous audience, people in the previous session to sit and create the audience. No, go to the first line. It's okay. Oh, yeah, it's okay. It doesn't matter. You are hearing it. It's okay. Yes. A very good evening to the moderators on the dais and a few of you all in the audience. My due in the next few minutes is to talk on the art of managing post-op surprise in cataract surgery. Basically, these are a group of patients, premium patients, who have been promised visual independence. And the fact that they have a residual refractive error, they are going to be after you to enhance them, to correct them, and get them relieved somehow. Just that group of patients. So first and foremost, we need to understand what is the source of this residual refractive error. It's quite likely, more likely to be an inaccurate biometry, wherein we have missed out those red flags, which is so critical. We need to look at the standard deviation. We need to look at the signal to noise ratio. We need to look whether there was a disparity between the two eyes, whether the K value was more than 0.3, whether the IOL power was more than 1 diopter. Everything needs to be looked out. We need to rule out whether it was a wrong IOL selection. Like the patient thought he's going in for a trifocal and has not understood that we were promising him an EDOF or an enhanced focal. So that's a wrong choice which you have done. It could be a transcription error or it could be a handwriting misinterpretation. So the best way to deal with all of this is to do your best before the surgery. So we need to use the right formula, and we now know that we have the 4th generation formula and beyond. And it becomes absolutely important for us not to hold on to what is old and gone and use the best, which is going to take care of all the extremes of situations. Ensure that the measurements are accurate, and if there is a disparity between two readings, repeat it. Sometimes it could be a dry surface because of which there's an error in our biometry measurements. We need to validate it. We need to ensure that the readings are consistent. The good news is that we know that the Hale RBF, the Barrett Universal 2, and the Emmetropia verifying optical formulas are all 92% of the situation within plus minus 0.5 diopter of target, and that is good news for all of us. We also know that in the segment of multifocal, the patients are not tolerant with the least amount of astigmatism, and we need to ensure that they get a toric multifocal. The problem is not there in 70% of the patients. In only 30% of the patients, you realize that look at the keratometry, the standard deviation is more than 0.2. Then could it be dry eye? Then if it is dry eye, treat it and then take your measurements. If it is not dry eye, it could be a refractive surgery eye, it could be an early keratoconus, it could be a PMD. Then you do a topography. You definitely need to do a tomography in these eyes. And if there is a toricity there, you need to use the toric calculator and need to use the best of the formulae and get the best of results in that 30% of the eyes. It goes without saying that it has to be a perfect phacoemulsification, a proper wound architecture, the proper overlap of rexes. It has to be a proper viscoelastic removal, and most importantly, before we step towards premium IOLs, we should ensure that our post-op outcomes are absolutely bang on optimal. So you also need to determine what went wrong. So first and foremost, you do a refraction, wait for a stable refraction, the cornea to clear up. It could be a post-RK patient when there could be some transient hyperopia. We need to look at the IOL, whether it's subluxated, there's a PCR. You need to repeat your biometry. Was there something wrong in the initial thing? We need to know that what was the biometry? Was it the IOL implanted, or was it a wrong IOL labeling when we need to remove the lens? Now, this was a patient who had a +8 diopter of residual refractive error, and which so clearly that something was bizarre in this patient, and it has to be addressed. But we need to follow the whole protocol, and in this particular case, we realized after checking all our records that it was a wrong IOL labeling. So then, in general, what are the considerations? I said stable refraction, it is mandatory. We need to look at the age of the patient. Do we need to repeat all the physical evaluation? Is he fit for a resurgery? Or what was the challenge in his primary case? Was it that his visual needs were not met? That he felt that his reading ability or the intermediate vision was not as good as promised? Could you have compensated by doing a binocular procedure? Is it that the dryness of eyes was a problem? Is it the zonules were weak, so the lens was decentered? And you also need to look whether there was a posterior capsular opening was there. Then we may not be able to very safely do an IOL exchange. So all of this needs to be done. We also need to plan when we are going to do an enhancement, whether you are going to allow for a neuroadaptation. But then, if it is a wrong IOL par as that situation, it needs to be removed. But if it is a cylinder and it's a toric IOL, you could even rotate it after max waiting for a week. Now, this was a patient, a 65-year-old with a small residual refractive error, as you can see here. And this needed to be addressed because he was coming back again and again. So we need to do a topography, need to do a refraction, need to see whether the cornea is thick enough to do a surface ablation or a PRK or a microkeratomy LASIK. But we need to be very, very sure, and majority of these patients, if you are taking good care of the dry eye by keeping them on artificial tears for more than 3-4 months, looking at the mebomitis, they are fine. Now, if it is a post-toric, we need to look at the refraction carefully, whether the spherical equivalent is 0. If the spherical equivalent is 0, you know this is the ideal case for a toric IOL rotation, and that would sort him out. In that situation, all you need to do is just to open up the incision, no viscoelastic, keep the infusion on, just reposition the IOL by just using a dialer. And in case it's a high myope, or you think that it keeps sliding back, you could even consider using a CTR in these patients. Going back to that +8 diopter, the only way for him was to have the IOL removed. So if it is hydrophilic acrylic, we don't even have to cut it. You could just hold it at the optic-aptic junction and pull it out. But if it is a hydrophobic acrylic, you need to hold it at the optic-aptic junction, and you need to cut the optic of the lens. You could do it just halfway and use that point as a fulcrum and pull it out, and then go ahead and replace with another IOL. Now, this was a patient wherein it was a +3 diopter of a residual, and the patient was advised a hydrophilic sulcoflex lens, and you know it has a large optic, it has undulating haptics, it has a posterior concavity which creates space between the primary IOL and this, and the material of the lenses need to be different, and that is the solution, and you can see the post-op vault was quite good. The second eye actually gives us a chance. I'm concluding. Basically, if the first eye was a VBT and the patient was wanting more near vision, you could do a panoptics in the other eye. If the primary IOL had a geometrics, you could do a geometric plus in the other eye. So there are different ways, and in this particular patient, his intermediate vision was clear, but his near vision was not good enough. So this was an old situation wherein a Technis +4 was given to this patient who was an avid reader and which was overlooked. This is a case again of a Symphony IOL, and the patient had a +0.5 for near, and all that you need to do is a micro monovision. But let's remember that between the two eyes, the disparity should not be more than 0.75, because that would affect the stereopsis of these eyes. So there are different ways you could deal with the second eye, but if a patient is 6/6 with a residual error but is happy, you could just leave him alone. So essentially, the content is that there are many ways which we could skin the cat, and residual refractive errors, if that is the cause for a patient dissatisfaction, it could be dealt with. Maybe we could wait for a breakthrough technology not so far away in future when there could be a post-op IOL par adjustment, and that is what the patient would need. Thank you very much.
Thank you, Dr. Chitra, for highlighting the management of post-op surprises. Next, we have a change of presenter. Next, Dr. Ramamurthy will be presenting on unhappy patients, unreasonable, manageable.
Dr. Chitra, just one question, madam. When will you plan the rotation or repositioning of the IOL? Yeah, toric. Yeah.
If the spherical equivalent has to be 0 when you do the refraction, that is +2 with -3.5 or something like that, you know that the spherical equivalent is 0. Those are the cases wherein you do a toric IOL adjustment, and then you need to go back either on eye trace or whichever there are different ways of checking that the Barrett RF formula.
Yeah.
You will know what is the axis of placement, and then you take the patient back to the theater. You could do it right away if it's a very high cylinder, but something small, they say that the maximum rotation occurs with the first hour, but you could wait even up to the week and see whether there's the IOL was
Okay.
thick and then.
Okay, thank you.